Hello.
Yes.
Hello.
Doctor, can we start?
Yeah.
Okay. Everyone can see the slides?
Yeah, can see.
Can see.
Okay.
Can see.
Okay, let me start now.
Why you?
So we are from group 5. About pancytopenia, also plastic anemia. Kavilan, next slide. Kavilan? Okay. Now, pancytopenia is a condition that occurs when a person has low counts for all the 3 types of blood cells, including red blood cells, white blood cells, and also platelets. So this pancytopenia is actually not a disease. It's just a condition where the number of blood cells are very low. Next. The causes of pancytopenia is megaloblastic anemia. So megaloblastic anemia is a condition which your body produces larger than normal immature red blood cells and have low red blood cell count. Aplastic anemia is one of the causes of pancytopenia where your body stops making enough new blood cells. Viral infection, such a viral infection by Epstein-Barr virus, will cause mononucleosis. Cytomegalovirus, HIV, and hepatitis also will cause pancytopenia. Gaucher disease will damage your bone marrow, and this eventually will also cause pancytopenia. Vitamin deficiency and liver disease are also other causes of pancytopenia. If this pancytopenia becomes more complicated or more severe, there will be a excessive bleeding where the platelets are affected, and also there is increased risk for infection if the white blood cells are infected. Next.
Hey guys, can you guys hear me?
Can.
Yes,
Okay.
Kavilan.
Okay, so I'm gonna present about the aplastic anemia. Yeah. So aplastic anemia is a disorder in which a multipotent myeloid stem cells are suppressed, leading to a bone marrow failure and pancytopenia also. The marrow often is virtually devoid of recognizable hematopoietic elements. It must be distinguished from pure red blood cell aplasia, in which only erythroid progenitors are affected and anemia is the only manifestation. So next, causes. Causes are divided into two: primary cause and secondary cause. So under primary cause, we have the congenital Fanconi anemia. The Fanconi type has an autosomal recessive pattern of inheritance and is often associated with growth retardation and congenital defects of the skeleton, such as microcephaly, absent redi, and thumbs. Other than that, renal tract also, like pelvic and horseshoe kidney, and under skin as areas of hyper and hypopigmentation. Sometimes there's a learning disability also. The second primary cause is the idiopathic acquired aplastic anemia. This is the most common type of aplastic anemia, accounting for at least 2 of thirds acquired case. In most cases, hemopoietic tissue is the target of an autoimmune process by oligoclonal aspiration of cytotoxic C2 A plus T cells. The secondary causes we have 5. First is ionizing radiation, like accidental exposure of radiotherapy and radioactive isotopes. Second are chemicals, like benzene, organophosphates, and other organic solvents. And other pesticides, recreational drugs, like ecstasy. Drugs, those are regularly cause marrow depression, like busulfan, melphalan, and so on. Viruses like non-A, non-B, non-C, non-G, in most cases, can cause this. Autoimmune disease. Under autoimmune diseases, we have systemic lupus erythematosus, thymoma. This is more usually associated with red cell aplasia. So for pathogenesis, there are two major etiologies. The first one is an extrinsic immune-mediated suppression of marrow progenitors. So activated T cells suppress hematopoietic stem cells. It is hypothesized that stem cells are first antigenically altered by exposure to drugs, infectious agents, or other unidentified environmental insults. This provokes a cellular immune response during which activated helper T cells produce cytokines such as interferon gamma and tumor necrosis factor that suppress and kill hematopoietic progenitors. This scenario is supported by experience with immunosuppressive therapy directed against T cells, which restore hematopoiesis in 60% to 70% of patients. The second one is an intrinsic abnormality of stem cells. An intrinsic cell abnormality is supported by observations showing that 5% to 10% of patients have inherited defects in telomerase, which, as mentioned earlier, is needed for the maintenance and stability of chromosome. It is hypothesized that the defect in telomerase leads to premature senescence of hematopoietic stem cells. Of further interest, the bone marrow cells in additional 50% of cases have unusually short telomeres, possibly stemming from as yet undiscovered defects in telomerase or excessive replication of hematopoietic stem cells. So we have a few clinical features for it. The first one is anemia, pallor signs of congestive heart failures, where you can find shortness of breath, and then thrombocytopenia, bruising of skins, gum bleeding and nose bleeds, and neutropenia. We have fever, cellulitis, pneumonia, and sepsis, and jaundice, and you can find weakness also. So for laboratory investigation, first we can see this anemia. This is a normorphomic, normycotic, and marcocytic mean cell volume. This reticulocyte count is usually extremely low in relation to the degree of anemia. This is the count of the neutrophil and the platelet. The bone marrow shows a hypoplasia with loss of hemopoietic tissue and replacement by fat, which comprise over 70% of the marrow. Trephine biopsy may show patchy cellular areas in hypercellular background. The main cells present are lymphocytes and plasma cells. Megakaryocytes in particular are severely reduced or absent. Other than that, severe cases shows neutrophils with this level and platelet with this level, reticulocytes, and bone marrow cellularity. Very severe cases show neutrophils in this level. Vicky.
Okay, the next one is the causes of anemia in chronic systemic disease. The first cause is the iron deficiency anemia. It is the most common type of anemia and caused by a shortage of iron in our body. When our bone marrow needs iron to make hemoglobin. When there is not enough iron in our bloodstream, our body can't produce enough hemoglobin for the red blood cell. The second one is the vitamin deficiency anemia. Our body needs folate and vitamin B12 to produce enough healthy red blood cells. When our diet is lacking in these vitamins and other key nutrients, it causes decrease in the red blood cell production. Next. Kavilan.
Padi.
Next slide, please.
Already.
Okay, thank you. Okay, the next one is anemia of inflammation. Certain diseases like cancer, HIV, AIDS, and rheumatoid arthritis, and other acute or chronic inflammatory diseases can interfere with the production of the red blood cell. The next one is the aplastic anemia. It is the autoimmune disease. This anemia occurs when our body doesn't produce enough red blood cells. The last one is the anemia associated with the bone marrow diseases. A variety of diseases such as leukemia and myelofibrosis can cause anemia by affecting the blood production in the bone marrow. That's all.
Thank you, sir.
Thank you.
So leukemia chronic disease, your presentation too short already. Also, you should describe about anemia due to renal disease, liver disease, like specific organ diseases. Yeah, yes. But you read that again. Okay, this I wanna a little bit quite short. If you anemia of chronic disease, actually a lot of theory. You read that from Hopran. Now continue with another people. MTS, right? Other group. Other group. Okay, other group. And this laboratory finding.
Hello, can anybody hear me?
Yes.
Okay, my group.
Who are you?
Kavi Varma. Okay, my group is presenting about myelodysplastic syndrome. You can hear.
Yep,
Yes. Continue on speaking.
Yeah.
Myelodysplastic is a bone marrow disorder. It's you can find it when there's an abnormal reduction in one or more types of circulating blood cells. Why this happens is because of the defective growth and maturation of blood forming cells in the bone marrow, which can sometimes progress to acute myelogenous leukemia. These are the classifications of myelodysplasia syndrome by WHO. There are ones with single lineage dysplasia, multiple lineage dysplasia, and with rings, sideroblasts, and excess blasts. And also there are myelodysplasia syndrome, they are unclassifiable. Okay. This is the table where you can find. Okay, if you want to classify each of them, it's based on dysplastic lineage. Some have more than one lineage, some have only one, some have no lineage at all. Okay, now I will go on to the next slide. Okay, this is the myelodysplasia syndrome with single lineage dysplasia. The first picture you can see.
What is single lineage
Second,
dysplasia?
yes, doctor.
What is single lineage dysplasia? What is multiple lineage dysplasia?
Single lineage dysplasia. Single lineage dysplasia. Single lineage dysplasia means the cells that have one lineage only.
So dysplasia occur
In only one cell. Hang on, doctor. Okay, single lineage dysplasia means this person has low numbers of one or two types of blood cell.
Yes.
Whereas multiple lineage dysplasia means frequent subtype of multidysplasic syndrome characterized by one or more cytopenia in peripheral blood. Okay, the next one is myelodysplastic syndrome with sideroblasts. You can see in the picture, the ones with the arrow are the ones they indicate. Okay, sideroblasts are nucleated erythroblasts, which are also precursors to mature red blood cell. They have granules of ions accumulated in their mitochondrions, which surrounding the nucleus. Okay, these are normally presented in the bone marrow, and they will enter the circulation after maturation into normal erythrocyte. Okay, the next one will be excess blast. Excess blast, you can see in the picture where it's the cytoplasm there's more cytoplasm than nucleus. Okay, next slide. Okay, this is myelodysplastic syndrome, which is unclassifiable because it doesn't fit any categories that was specified before. Okay, now the cytogenic abnormalities in myelodysplastic syndrome. Okay, Each disease karyotype is contributed to the International Prognostic Scoring System. This is a system that is used for the prognostication of myelodysplastic syndrome. The individually acquired cytogenic abnormalities, they are found in 40 to 50% of cases of myelodysplastic syndrome, are used in diagnosis cases of each disease and the management. To identify identification of these specific genes, the specific genes that are affected by each cytogenic abnormalities are very challenging, and some of the consequences are still elusive. But they use these cytogenic abnormalities to diagnose some of the cases. Okay, one of the abnormalities are deletion of the long arm of chromosome 5. This is the most frequent chromosome abnormality found, which is up to 50% of the diagnosed cases. Okay, these cases exhibit heterogeneous clinical picture, which can be divided into two large classifications based on the clinical pathology features. Okay, one of the subtypes that arises from these cases after prior exposure to cytogenic chemotherapy and radiation exposure often show additional chromosomal abnormalities and TP53 mutation. These subtypes have increased likelihood of leukemic transformation and a shorter overall survival. They range from 6 to 17 months, depending on the number and severity of the abnormalities. However, overall, patients with isolated deletion of chromosome 5 have a relatively better prognosis and a reduced risk of progression to acute myeloid leukemia. The next one is monosomy 7, which is either known as monosomy 7 or deletion of chromosome 7. Chromosome 7 abnormalities are correlated with worse prognosis and reduced overall survival in myelodysplastic syndrome and also other myeloid malignancy. The common deleted region in chromosome 7 that is identified are located at the position 7q22, 33 to 33, and 35 to 36. They are all on the chromosome 7. There's also the MLL5 gene, which is encoding a histone methyltransferase, which is another gene mapped on the 7q22 chromosome. Impairment of this gene will result in impaired neutrophil function, erythropoiesis, and a decrease in repopulating capacity of hematopoietic progenitors, which is even present in the self-renewing stimulus. However, abnormalities in this gene are not found in myeloid neoplasia. However, reduced expression of this gene doesn't correlate with the poor prognosis of acute myeloid leukemia. Okay, next one. Okay, trisomy 8. Trisomy 8 is also another common type of cytogenic abnormality. Isolated trisomy 8 occurs in approximately 5% of all patients with myelodysplastic syndrome and is correlated with intermediate prognostic risk. The median overall survival of each individual is around 23 months. Okay, one hallmark of trisomy 8 myelodysplastic syndrome is the chromosomal aberration, which is thought to occur late during the disease pathogenesis, as evident by its detection in myeloid progenitors and near absence of CD34 stem cells. Trisomy myelodysplastic cell express high levels of anti-apoptic proteins such as survivin and exhibit strong resistance to apoptic stimulus. The knockdown of these apoptic proteins abolishes the survival advantage of trisomy myelodysplastic clones and represent a potential target targeted therapy can be used in subgrouping of these patients. Another cytogenetic abnormalities can be found in the sex chromosome abnormalities. Acquired loss of sex chromosome, both in male and female, are age-related phenomena which can occur in association with hematological malignancy. My MDS patients with isolated loss of Y chromosome are classified under a very good prognosis group, because in the first discovery of 1966, in 1960s, the deletion of Y chromosome and its relation with myeloid disorder has been under scrutiny. Since the loss of Y chromosome has been attributed to normal aging process, the fact where MDS incidence increases with age and the association between the Y chromosome and MDS is unclear. On the other hand, the loss of X chromosome in female patient is a relatively rare defect. Around to 0.2 to 0.3% of patients are found. Okay, the X chromosome in combination with other chromosomal abnormalities and correlates with intermediate prognosis, where patients have an overall survival rate of 16 months. Okay. Turner syndrome is defined as a constitutional loss of X chromosome. However, patients with Turner syndrome do not seem to have increased risk of developing MDS and other hematological malignancy than the general population. Next is trisomy 21 and monosomy 21. Constitutional trisomy 21 is very well known in the context of Down syndromes and is associated with increased risk of acute myeloid leukemia and other acute lymphoblastic leukemia. Besides being a hereditary disease, trisomy 21 also may occur as a clonal cytogenetic abnormality in hematological malignancy. Like trisomy 13 trisomy 21 occurs much more frequently in acute myeloid leukemia than myelodysplastic syndrome. They occur around 0.3 to 0.8% of MD myelodysplastic syndrome cases, and is classified as one of the rare cytogenetic abnormalities in this disease. Okay, these patients show low absolute neutrophil count with mild anemia and thrombocytopenia. Okay, patients with isolated trisomy 21 are classified in the intermediate risk group, though some studies have reported could be better fitted in the poor risk group. Okay. Monosomy 21 is also another type of rare cytogenic finding in myelodysplastic syndrome, found in only 0.3% of cases. However, in combination with other abnormalities, they found in there is a 0.5% in cases. Okay, like trisomy 21, the impact of isolated monosomy on the prognosis of patient is limited. Why? This is due to the insufficient number of patients in studies and is currently categorized under the intermediate risk group. Okay, monosomy 21 may present as a technical artifact and occur randomly while cells are prepared for chromosomal band analysis. However, the finding may not represent a true monosomy and should be confirmed with additional techniques such as fluorescent in situ hybridization to avoid false positives. The clinical features of myelodysplastic syndrome. Okay, myelodysplastic syndrome is a disease of the elderly, where half the patients are over 70 years old and less than 25% are less than 50 years old. Myelodysplastic syndrome cases have a history of exposure to X-ray, cytogenic drugs, leukemogenic chemicals. Many cases are also presented with incidental blood count. Okay. In myelodysplastic syndrome, there are 3 myeloid cell lines in the bone marrow that are affected, which are granulocytic, erythroid, and megakaryocytic. MDS affects one or more types of myeloid cell lines, resulting in either anemia, neutropenia, or thrombocytopenia. Anemia is a condition which is where you lack healthy red blood cell to carry adequate oxygen to your blood tissue, to your body tissue. Anemia caused by MDS is normocytic or macrocytic, which means it's non-megaloblastic. Okay. The hemoglobin count is typically less than 10 grams per deciliter. Okay, and the reticulocyte count is also normal to low, and patients with this kind of disease, with this condition, are usually transfusion dependent. Okay. Neutropenia is when the person has very low levels of neutrophils. Neutrophils is a type of white blood cell that helps fight infections and by destroying harmful bacteria and also fungus in the body. Patients with MDS commonly have neutrophil count of less than 1,800 per microliter. The next clinical picture is thrombocytopenia. Thrombocytopenia is a condition where you have low blood count. Thrombocytes help in blood clotting and stops the bleeding by clumping and forming plugs in blood cell vessel. Okay, these patients usually have blood counts of less than 100,000 per liter. Another clinical feature of myelodysplastic syndrome is organomegaly, which is enlargement of a particular organ. Usually, you will find these organs that are affected are the liver or the spleen. This is not commonly observed in myelodysplastic syndrome, in contrast to myeloproliferative neoplasm. Okay, example of it is chronic myelogenous leukemia, which is associated with the enlargement of the liver and spleen. Okay. The clinical manifestation signs and symptoms. Okay, the symptoms experienced by myelodysplastic syndrome patients are related to the type and the severity of peripheral blood cytopenias. For example, if a patient is suffering from anemia, you will see that the symptoms are you will have excessive tiredness, shortness of breath, and pale skin. Okay, serious infections with high fever can be caused by leukopenia, and in particularly by having neutropenia or granulocytopenia. Okay, the last one is excessive bruising and bleeding, which can be seen in which you can see is as frequent nose bleeding or bleeding in the gums, which is due to thrombocytopenia. Okay, the next slide will be presented by Ragesh.
And then laboratory findings of MDS. Diagnosis of MDS should be considered when patients have unexplained blood cytopenia such as anemia, neutropenia, or thrombocytopenia. Then complete blood cell count and blood semen examinations. These measure anemia, which is usually macrocytic or normocytic, neutropenia with a dysplastic features, or thrombocytopenia. And then the platelets may be normal in shape, giants, or hypogranular. And the second one is bone marrow aspartate and biopsy examination. The bone marrow may measure normal or hypercellularity with varying degree of dysplasia within the three myeloid cell lines. There are three dysgranulophosis, dyseptrophosis, and then karyophosis. And then the percentage of bone marrow blast measured during bone marrow aspartate or biopsy analysis typically ranges between normal less than 5% to increased 5 to 19%. The subtypes of MDS. An increased rate of apoptosis, that is degenerating cells, is a common MDS findings and is a contributing factor to the presence of cytopenias. And third one is bone marrow cytogenetic examination. In that, abnormal cytogenetic findings are observed in approximately 50% of the MDS cases. According to the International Prognostic Scoring System, MDS with 5 deletion chromosomes has decreased likelihood of developing into AML, that is a good prognostic score. And then MDS with the practical deletions of 11 as an intermediate prognostic score. Deletion of 7 chromosome and trisomy carry carry a poor diagnostic score, and that is increased incidence of developing AML. Last one is bone marrow flow cytometry may show normal or increased blood counts, monoclonal antibodies that are reactive to blast cell surface. Markers are used to determine the number of blasts. Example CD34, HLA, DR, and CD117. Correlation between the blast counted differentials and flow cytometry an important aspect of MDS evaluation process. And then blood iron, B12, and folic acid levels. The anemia, neutropenia, and thrombocytopenia are not due to mutational factors of MDS. Antibody test would be normal, as well as vitamin B12 and folate levels. And these tests are performed prior to evaluating the cases as possible in MDS. Then immunophenotyping. There should be good correlation between the blast determined by flow cytometry, that is antibody to CD34 plus or CD117 plus cells, immunohistochemistry, antibody to CD34 plus or CD117, and right Gimsia stained aspartate simmer. In some cases, this is a discordance between the three methods due to sample quality, bone marrow fibrosis, or hemodilutions. In such cases, immunohistochemical stains on the biopsy section, antibody to CD34 plus or CD117 plus cells become very valuable in staining the blast and determining the diagnosis. Thank you.
Okay, that's our slides. Everyone can hear?
Testing.
Yes, can hear Gary.
Okay, so
That's my
Doctor,
yeah. Anything?
I don't know. For some reason, your mic is muted. Okay.
So plasma cell are differentiate from what cell? You should know was from B cell. B cell, T cell is B cell to plasma cell, and then you can secrete immunoglobulin, right? So they can differentiation of B cell. But in this abnormality, immunoglobulin increase is single homogeneous. It means or one type of immunoglobulin, for example, IgG or IgA, or only one type is especially increased in this type of, and this dyscrasia. So this is normal immunoglobulin light chain, heavy chain. This land in biochemistry, I think, light chain, heavy chain, GAMT. So in plasma cell dyscrasia, only one type will increase, especially increase. So normally they can differentiate many different types of antibody. In myeloma cell, mainly only one type of antibody and too many. This means homogeneous monoclonal. This term you must know in other tumors also. So land the term monoclonal. Monoclonal means one type, but too many. Monoclonal, we usually want to take only one type. In tumor, only one cell type are predominantly increased. Other types suppressed. For example, leukemia also the same, right? Only one cell type became predominant usually, except chronic myeloid leukemia. So its incidence 50% of death caused by lymphoid neoplasm. What protein? This monoclonal immunoglobulin. What protein? M protein. You should know myeloma. For myeloma, so M protein or paraprotein is increased in this here. This is just for knowledge. M protein. This slide is just for knowledge. M protein increase. This also produce only light chain. This will learn again later. Lambda kappa or lambda. Pancytopenia protein. This point is point for MCQ. Pancytopenia protein you can see multiple myeloma, not in leukemia. Pancytopenia protein. It's light chain protein. What is Pancytopenia protein? It's light chain protein, maybe kappa or lambda. They can detect in blood or especially we detect in urine. It's diagnosis point for multiple myeloma. Pancytopenia protein in the urine, you can tell the patient have multiple myeloma. This can be X-ray. This is just for theoretically only. This crystal we rarely do X-ray. So plasma cell dyscrasia synonym. Monoclonal gammopathy, dysproteinemia or paraproteinemia. These are just synonym, the similar names. So what include classify plasma cell neoplasm by WHO, MCAS, monoclonal gammopathy of undetermined significance, plasma cell myeloma, plasmacytoma, and osteosclerotic myeloma. But for you must mainly know plasma cell myeloma is enough. Others for you not for your level not essential. If you know plasma cell myeloma is enough for you. Others classify plasmacytoma. It's all kind of tissue called plasmacytoma, immunoglobulin deposition disease, amyloidosis, already teach. Osteosclerotic myeloma. This are not too essential for if you are not hematologist. If you know plasma cell myeloma is okay. MCAS is just for MCQ. What is MCAS? Monoclonal gammopathy of undetermined significance. This means presence of M protein in patient without sign symptom of plasma cell disorder. I will teach later sign and symptom of plasma cell disorder, but this patient undetermined significant patient, they have M protein present, but no sign and symptom. Very common, older. Sometimes they can transformation to symptomatic. Sometimes even multiple myeloma. Their criteria: plasma cell less than 10%, myeloma is more than 20%. Paraprotein, immunoglobulin. So myeloma is different from leukemia. Protein level are increased. What protein? Paraprotein. Another one, immunoglobulin. Any feature? Nothing. Can be progressed to myeloma 1% per year. This is just for MCQ. Flow chart how myeloma occur. So post B cell, then MCAS, smoldering myeloma, then multiple myeloma and plasma cell. If leukemia means multiple myeloma may stay in the bone marrow. If this myeloma cell arrive more than 20%, a lot in peripheral blood, we can tell the term, we use the term plasma cell leukemia. If stay in bone marrow, we use the term multiple myeloma. Sporadic, if you Now, myeloma, okay, you can forward bordering multiple myeloma. Multiple myeloma means the plasma cell more than 20% or 30% in bone marrow is multiple myeloma. If this plasma cell are seen a lot, normally plasma cell less than 1%. Plasma cell usually you cannot see in the blood film. You can see RBC, WBC, platelet, this only. If you see plasma cell a lot, more than 20% in the blood film, this is called plasma cell leukemia. This is plasma. This is 3D effect. Plasma cell, very big blue color plasma cell. So this is this outline you should know: definition, risk factor, pathogenesis, clinical feature, investigation, prognosis, management only. Management just for knowledge. Incidence. What is multiple myeloma? Plasma cell, neuroplasm. From this slide, you need to read from study from this slide. You need to read from essay question. Multiple myeloma. So definition. Firstly, definition. What is multiple myeloma? Plasma cell accumulation, bone marrow, location bone marrow. And what present monoclonal protein in the serum or urine. This can also cause tissue damage in symptomatic patient. More common in African age 65, 70. So, what is M protein? M protein can be intact immunoglobulin like GA, usually G and A, and rarely G and E. Or pair of IgG molecule may be free light chain, kappa or lambda. Mostly IgG, 60%, IgA, 20 to 25%. This point you should know for MCG. Mostly IgG, second IgE, not IgG and IgE, very rare. In cases for M protein, what is M protein? This is M protein. Strong protein is light chain, kappa or lambda. Sometimes this food you can see. If you forgot, this is just for knowledge. This slides maybe non-secretory or secretory. Risk factor: age, race, gender, male, genetic, first degree, relative. Exposure is the same, more or less the same like leukemia. Other risk factor: SLE, immune stimulation, and obesity. This can cause myeloma. It's the same previous issue because of gene, what gene mutation and chromosome. Simic 30 to 40 deletion, activation of KRAS. So as indication, neoplasia cancer is multi-orchestra like multi-step mutation and deletion in gene. This can transfer to cancer. So how pathogenesis? The bone marrow produce B cell is arrived. Can we invite? Right. Yeah. Who is anyone please mute your mic too loud. This pathogenesis is if you pathogenesis a little bit difficult if you depends on you if
Doctor, I cannot hear you.
Doctor, cannot hear.
Yeah. Or bone destruction organ. Bone destruction is mediated via this myeloma cells produce cytokine mediated epithelial bone destruction mediated by bone resorption activity here. This rank TNF and here rank here this mediator bone myeloma cell produce secrete same cytokine. This react with here the osteoclast become active and this can cause bone destruction. If you forgot this, pathogenesis is not too important for you because of this a little bit complicated. You are too molecular level. So if you cannot remember, it depends on you. Not too important because of quite difficult, too molecular level. I think you will forget. Even I give repeat again and again for remember when I was saying that. For master level, they ask pathogenesis, but undergrad level, this pathogenesis is quite difficult. If you forgot this, no problem. Not too important for you, this pathogenesis. If you can understand also can be, it's very too molecular. So for your level MBBS, if you generally know multiple myeloma and have no need to DT, this is need to know by hematologist pathogenesis. If you just know how generally pathogenesis how occur, myeloma cell produced by gene defect, and then this gene defect, then this abnormal myeloma cell inhibit apoptosis and also stimulate cytokine. This can cause osteoclast stimulation of osteoclast in the bone, and this can cause bone destruction. Your idea is myeloma cell produce cytokine. This can stimulate osteoclast, and this can cause bone destruction. So in multiple myeloma, bone destruction is very popular in compared with CML, leukemia. They can even present with bone fracture. They are clinical feature, bone pain, fracture, pathological fracture. I mean, even you not fall down automatically. Even your minor injury, this can cause bone fracture. So you must include bone pain and pathological fracture in multiple myeloma because they are myeloma cells pathogenesis. They can destroy lipid bone lesion is very popular here. In compared with leukemia, leukemia is bone marrow expansion and can cause bone pain only. Here, even they can produce fracture also, bone fracture. So outline, okay. If you can remember, outline is enough for pathogenesis. No need too detailed like here. This is too detailed, too molecular level. So for your level and not too essential, you will forget also. Rancor, if you forget rancor and something, stay okay, no problem. So understand outline. I understand outline pathogenesis. Okay, outline, just outline only. Okay, no need too detail. I already summarized you outline. No need too detailed. No need too CD, CACR4. This can be, and you know this one CACR4 for CACR5. Sometimes they can use in CACR5 or 4 and for going HIV patient. This receptor deficient, they cannot suffer HIV. And this is here 5 or something, 4 or 5 and 4 HIV, not here. If you firstly you remember genetic damage, this can cause This can genetic damage. First, genetic gene damage can inhibit apoptosis and can cause cytokine cascades. This cytokine cascade can stimulate osteoclast. This osteoclast means bone destruction cell. Activated osteoclast. This can cause like bone begin lysis. This is key point. Okay. Sham okay.
Okay, doctor.
Sham okay. This only. So where Pan Yong Sham also okay. Pan Melissa. Pan Yong Sham. Where Pan Yong Sham?
Yes, doctor.
Oh, are you okay?
Yes, okay.
Just outline on me. Where Shafiq? Shafiq. Okay. Where Shafiq? Shafiq disappearing. So clinical feature. Myeloma cell. How pathogenesis and clinical feature correlation. Myeloma cell produce abnormal protein. This can cause monoclonal protein can cause neuropathy. This hyperviscosity. And this can also affect renal because of abnormal protein can block renal. This can cause renal failure and this can transform to a myeloid. Because myeloid is also abnormal protein synthesis. This abnormal immunoglobulin, decrease in immunoglobulin and neutropenia can cause infection. Hypercalcemia caused by bone destruction. And bone marrow infiltration can cause suppressed other synthesis and anemia. Neutropenia is followed. Like in leukemia. Leukemia also produce anemia. Thrombocytopenia here also can produce anemia. Can produce thrombocytopenia also. Another one here. Every malignancy can present with hyperglycemia, but bone marrow here, myeloma is most significant because they destroy bone and this hyperglycemia is most significant here. Also, renal failure caused by abnormal protein. Neuropathy is all caused by abnormal monoclonal protein. Monoclonal protein can cause renal failure, hyperviscosity, myeloid SCTT, light chain deposition. If you don't know light chain deposition, this is also okay, no problem. Immune deficiency, bone pain, hypercalcemia. This is myeloma kidney. You can see here protein cast. Finger presentation. You can see M protein in serum or urine. Skeletal involvement 80%. Here you must include in clinical feature skeletal involvement. It's very popular sign. So can present with bone pain, fracture, even fracture. In leukemia, they rarely present with fracture or nearly zero. Here they can present with fracture is quite popular. Osteoporosis and hypercalcemia because of they destroy bone. You can see little lesion of bone with X-ray also. So leukemia, so you can use X-ray or scar, spine, pelvic bone. You can take picture. You can see little bone lesion. Anemia, anemia features and immune function deficient because of they are immunoglobulin synthesis defect. So immune function deficient. Another one is thrombocytopenia. How mechanism? Myeloma protein function of interfere platelet function and coagulation factor. This can cause abnormal bleeding. So Shan, CML, CLL can present with bleeding or not? CML and CLL. Shan. Chronic myeloid leukemia and chronic lymphoid leukemia present bleeding or not?
CLL is not. CML is yes.
CML, what stage they can present with bleeding? CML 3 stage. What stage?
That one I'm not sure, doctor.
Yeah?
I'm not sure.
Quite easy. Blood crisis phase, quite easy. Blood accelerated phase, chronic phase. Usually they not present with bleeding. Blood crisis phase only. Blood crisis phase usually actually chronic phase never present bleeding, very rare because of even platelet count increase. Because they are tyrosine kinase can increase platelet count also.
Okay.
You stay now, right? You haven't finished.
No, I just finished hemolytic.
You not finished leukemia. Yeah, lymphoma again. Myeloma. Again. Myeloma is quite second line in compare with leukemia. Leukemia are more important. Myeloma quite rare. I see some patients only, not too common. Leukemia is common. You will see a lot of leukemia in child and adult also. And the MDS also quite common. You will see in clinic. MDS usually myelodysplastic syndrome is usually prognosis not good. Usually patient die within short period. Prognosis not good. MDS usually I see in clinic hematology well when I do for this is MDS patient. Prognosis not good. They difficult to treat. Another one, renal. I highlight renal failure. Because of protein, abnormal protein. If you drink a lot of protein fluid, who is gym? Fight, you go to gym, right? If you drink a lot of protein, wheat protein, this can cause renal failure also. Here applying the same. Abnormal protein.
No.
Why not go to gym? If you drink a lot of wheat protein, can cause renal failure. Here you can apply the same. Abnormal protein. Myeloma is abnormal protein synthesis. This can cause immunoglobulin and abnormal paraprotein. This can cause block in renal and can cause renal failure. You must include renal failure so I will continue. This feature must include protein, skeletal involvement, and renal insufficiency, hypercalcemia. These are compulsory because in clinical feature you must not include this main skeletal involvement, renal failure, hypercalcemia. These are compulsory. Neuropathy, 20% can be they explain with paraprotein only. Another one, hyperviscosity syndrome. This can produce CNS symptoms like neuropathy and heart failure. Because of the blood became little bit hyperviscosity can cause blockage. Block in the artery vein. This can cause visual failure, CNS symptom, neuropathy, and heart failure. Amyloidosis is 5%. So IMWG criteria. You just remember this myeloma, okay? MCAS smootering if no need to for you. You just remember this myeloma, active myeloma is enough. For this two is just for knowledge. More than 10%. Usually we got more than 20% also in some definition. At least one of the following criteria features. This is more than 10% plus at least criteria all three require more than 10% of plasma cell and bone marrow and protein in serum or urine, or at least one of creatine, calcium, and army renal dysfunction, creatinine more than 20 mg per deciliter, anemia or bone involvement. This two plus at least one, you can tell. This 1, 2, and this any one, this you can tell. This you have myeloma. This patient has myeloma. This two feature plus at least one, 2 to 3 feature you need. More than 10 and protein plus any one. You just remember this is the myeloma diagnosis criteria. So now laboratory. Let's say blood flame, bone marrow, flow cytometry, immunophenotyping, chromosome. These are the sequence only in all myeloma, lymphoma. Another one, leukemia. Blood flame, bone marrow, immunophenotyping, flow cytometry, chromosome, genetic, this the same format only. Here, imaging add-on, you must remember. Imaging needed here because they can detect bone dysfunction. Imaging is necessary in myeloma in compared with leukemia. Another one, beta-2 microglobulin and albumin can for staging and prognosis. So, complete blackout. I think this three quite easy to understand because anemia, leukopenia, or penia. Blood flame, here, relay formation. This is characteristic of multiple myeloma. For MCQ also. Relay formation here, RBC overlap. Likewise, RBC overlap each other. This cause of abnormal, normally relay formation in RBC. Because normal RBC do not stick each other because they normally they have negative charge each other, so they cannot stick each other because of negative charge in RBC they can prevent stick each other. But in multiple myeloma, the protein coated this negative charge, so the negative charge can disappear and RBC can stick each other and become relay formation. RBC relay RBC stick each other, overlapping. This is when you see this in blood flame, you can tell this features of increased paraprotein multiple myeloma. One of the character of multiple myeloma. Relay formation. Plasma cell can be 50%. If plasma cell more than 20% is called plasma cell leukemia. Bone marrow increased plasma cell more than 20% here diagnosis. Heterogenic analysis, mutation, aneuploidy translocation, aspiration more than 20%, and suppression of other cells. So they can present with anemia, thrombocytopenia, and neutropenia. Their character, you should know this character of myeloma cell. The large blue cell cytoplasm is very blue, and centric nucleus is stick to the periphery one side, and nuclear halo is quite a little bit difficult to see. Perinuclear halo, little bit white color around the nucleus, and the whole is brown color. You can see even two nucleus in this myeloma cell. These all are myeloma plasma cell myeloma. So serum protein electrophoresis, serum immunophenophysician electrophoresis, FSCM free light chain assay. Investigation, you must include this one, serum protein electrophoresis. You can see and spike in beta or gamma region here. Serum protein electrophoresis. You can see spike. This is called spike. Maybe IgG or IgM. This always performed in combined with immunophysician. You must include this electrophoresis serum protein and immunophysician. This can identify light chain, heavy chain type, and 24-hour urine here. Pancytopenia proteinuria. Protein electrophoresis, you can see and spike. What is and spike? Monoclonal heavy or light chain. Immunoglobulin quantitative, so you can see increase in IgG and IgA mainly. Another one, 24-hour urine protein, all are associated with protein and immunoglobulin. This explanation is just for knowledge. I want to show this figure. And you need to write from this only. Lab diagnosis, protein electrophoresis, immunoglobulin, quantitative immunophysician, 24-hour urine protein. Immunophysician is more sensitive. Why you need to do both? Because immunophysician does not give estimate site of M protein. So serum protein electrophoresis always should be combined with immunophysician. This can determine the type IgG, IgM, and light chain reaction kappa or lambda. As you can see, M protein increase only. Immunophysician, you can confirm type M protein, what type? G or M or light chain or kappa or lambda. These are accessory. Radiology, you can see lytic area. Phosphorus, hypercalcemia, creatinine, is venous function, total and differential protein, low albumin. Beta-2 microglobulin can be increased. Radiology. So investigation important now. What and the bone marrow and blood in everybody will need to write. Another important is serum protein, electrophoresis, immunophysician, radiology. These are most important investigation you must include. Others are accessory. So MRI, X-ray, MRI, you can see here, multiple myeloma, here, lytic lesion in the bone. And spine, multiple myeloma, you can see lytic lesion in the spine here, and even spine compression occur, and fracture. How you can diagnose bone pain or back pain is not improving? Then check if this criteria present. According to the criteria, previously I already what criteria for diagnosis of multiple myeloma? Prognosis is variable. Median survival 4 to 7 years. If this feature present, post prognosis. Cause for death, infection, renal failure. Fish, another one after general laboratory, another genetic. You just remember 1 or 2 chromosome is enough. No need for example, you remember deletion B70 or T40, 20 or any 1 or 2. If you remember, okay, no problem. Yes, so I finished now. Case study beginning. So I will ask who where Farzan not here. Farzan, do we have Zen?
D Fazrin as well.
Yeah?
His name is D Fazrin as well.
Oh.
Like.
So 5 Farzan not here. 5 case study.
Yes.
So please point out me the point for diagnosis.
Dyspnea. Hematuria and proteinuria.
hematuria it can be, but this is not significant in here. Proteinuria is more correct. Another feature. So hematuria you can confuse with other diseases.
Immunofixation positive for kappa reaction.
So why you forgot here? Patient will present with this symptom first.
Oh.
Patient will present with this symptom first. Chest pain dyspnea, you can be confused with myocardial infarct or something also, right? Chest pain dyspnea, you can confuse with coronary artery disease. Here is more clue for diagnosis. Lower pain without trauma. Fatigue can be another one. Proteinuria is so sad. This is also quite correct because this chest pain dyspnea you can confuse with cardiac disease. This cannot. This is no specific for myeloma. Myeloma can present with heart failure also, but you can confuse. If patient is 60-year-old, he can before myeloma he can have myocardial infarct or atherosclerosis also, so you can confuse a little bit. Back pain, so bone pain is more characteristic sign of myeloma. Okay, sham, understand? Sham, where is sham? Sham. Wait, Tanusha is so silent, sleepy.
No, sir.
Where is sham? Sham. So case study is baseline. Complete background and chemistry. I highlight already the criteria. I need to do bone. Crab criteria present or not? You need to study from this analysis, and then you should map with crab criteria. Additional testing, bone marrow, cytogenetic, and fish. Should know. Bone marrow, what they see, plasma cell 20%. Diagnosis, symptomatic multiple myeloma. If you forgot kappa light chain tie, it's okay, no problem. For your level only, just you diagnosis multiple myeloma enough. Because of here, serum kappa light chain, they definitely diagnosis kappa light chain tie. But for you in exam, if I ask you a scenario, you no need to write what type, just write multiple diagnosis, multiple myeloma correct enough. No need too specific. Just generally is okay for you. It's paraproteinemia. It's abnormal protein is quite easy to be by myself only. Abnormal presence of monoclonal immunoglobulin plant in serum is called paraproteinemia. This can reflect a single clone plasma cell synthesis immunoglobulin, monoclonal band of M protein. Or this is called paraprotein. Because of plasma cell synthesis abnormal protein and protein, this is called paraproteinemia. For this John Hodgkin, if you know this table, this just for knowledge. Just remember what is paraproteinemia is plasma cell synthesis immunoglobulin abnormal monoclonal and band and protein is called paraproteinemia. Just no definition only. Definition for knowledge. You should know what is paraproteinemia. The term is an meaning. What is paraproteinemia? I ask you know the term is an abnormal monoclonal band and protein or paraprotein. Due to myeloma cell produce abnormal protein immunoglobulin synthesis. Okay, finish. Myeloma is need to know is what myeloma risk factor. Definition, risk factor. Pathogenesis, clinical feature. Pathogenesis is just for knowledge. Clinical features and laboratory investigation. This only. Laboratory investigation, you can need to write this table only. This physician and this two slides no need to write. Table only. This table This table only. These two slides I use for explain what is electrophoresis and physician only. So this is a prognosis and prognosis. So okay. Definition, risk factor, clinical features, and outline of pathogenesis, then lab diagnosis and prognosis. Myeloma, you need to read myeloma also. So bye. So okay, you can study back. And tomorrow is I want to say later. Tomorrow is predicate. Predicate is quite slight discussion only, quite easy, short period only. I was predicate for hemodynamic disorder, but just photo and teach only, so quite short duration tomorrow.
Thank you, doctor.
Thank you, doctor.
Bye.
Bye, doctor.
Bye,
Good day, doctor. Thank you.
See you tomorrow.